Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Welcome to this edition of 5 Slides We're Discussing. My name is DJ Wilson, one of the hosts here at State of Reform, teeing up conversations like this one that cross the partisan divide, cross the divide between public and private, and try to create a safe table where we can gather around and have conversations about the future of policy, the future of healthcare. And I'm super excited to be hosting this one here today. It's a good conversation. We've got about 110 of you or so in our room focused on gene therapy and rare disease and Arizona policy. So I appreciate everybody gathering around. Just as a quick word, of course, our conversation today has this chat box on the right, and you are, of course, welcome to offer your 2 cents, your comments as we navigate through this conversation. Don't want you to be shy. I know you're not a shy bunch. And if you see a comment you like, you can upvote that by clicking the thumbs up icon. Throughout the conversation, I'll weave those in as maybe warranted. If you got something that you want me to tee up, I'll do my best to make sure that's included. This conversation is being recorded. It'll be available at stateofreform.com, so you can come back and take a look later, forward this around if you'd like. Without further ado, however, I'd like to jump in to introduce our panelists here today for this topic. I appreciate all of them making time. First, we've got Dr. Rafael Fonseca, the Chief Innovation Officer at the Mayo Clinic, Dr. Jennifer Hodge, the U.S. Gene Therapy Lead for Pfizer, Danny Seiden, the President and Chief Executive Officer of the Arizona Chamber of Commerce and Industry, and Dr. Sharon Hesterly, the Chief Research Officer at the Muscular Dystrophy Association. Thank you all for being with us here. Danny, let me ask you first, give us a rundown of some of the work you're spending your mental energy on these days.
Oh, these days, as always at the Chamber, we're focused on one thing, that's making sure that Arizonans have access to innovative, affordable healthcare, and making sure that the free market solutions are what's getting us there. So, with the session just starting, just the other week, it's a busy time. We review all the bills as they come in, some good ones, some bad ones, play a little offense, play a little defense. But we're going to do what we can to make sure Arizona stays at the forefront for innovation for all of health.
Yeah, good stuff. Jennifer, how about you? As the lead for Pfizer on these topics, what are you spending your mental energy on?
Yeah, thank you, DJ. So I'm an immunologist by training. I'm the team lead for the rare neurology group in the US at Pfizer. And so I'm spending my time getting ready for the US Duchenne muscular dystrophy gene therapy program. So happy to be here and talk a little bit more about that and what it means for Arizonans.
Yeah, good. And Rafael, how about you? As Chief Innovation Officer at Mayo, what are you spending your mental energy on? What's commanding your attention these days?
Thank you. Thank you for the opportunity. First, DJ, it's a pleasure to be with you all here. Actually, my energy has to be divided by its own nature in several realms. So, as Chief Innovation Officer, I work with other stakeholders in the state and the city for the same purpose of what Danny was saying. We want to bring cutting edge innovation for the state of Arizona and to be participants and drivers in finding those solutions for the future. Part of my job is being in charge of some of the development that we're seeing and experiencing around the Mayo Clinic Hospital in North Phoenix, and also to be the liaison for Arizona State University, which we have a very strong partnership with. So that's where I spend most of the energy these days.
Yeah. And Sharon, how about you? What are you giving your precious energy to here in 2022?
So the Muscular Dystrophy Association is a national nonprofit organization, and we provide funding and care for over 300 different rare genetic neuromuscular diseases. So we've invested heavily in the development of gene therapy, and now we're focused on how we make that a reality, especially for some of the disorders in our program that are maybe not as commercially viable as others.
And MDA used to be based in Arizona for years, yeah?
That's correct. For about 20 years here in Tucson, and I myself am still based in Tucson. So yeah,
holding down the fort. Well, I appreciate all of you making time very much, and of course, when COVID hit, we all moved into this virtual space. One of the things we thought was, of course, the need for these safe tables continued, and of course, really got more important, I think. But we wanted to do them a little differently, meaning we wanted to use the tools of this virtual space to elevate and change the kinds of conversations. So we have titled this appropriately, 5 slides we're discussing. Each of our panelists has brought a graphic, a slide that they want to talk through. I've contributed one. We're going to spend our time going through each of those here. And we want to start with yours, Sharon. Tee us up or walk us through what you have here on the screen with your first slide.
Great. So I wanted to bring this home to Arizona, and I can show you an estimate of how many people we think are living with neuromuscular diseases in Arizona who might benefit from gene therapy. So we estimate about 5,500 people, and you can see on the side that I've broken down some of the more common rare disorders and the estimates of how many people in Arizona are living with these disorders. What I've also done is color coded them so that you can see that in green, we have an approved gene therapy for one of the disorders on this list. And we also have gene therapy in either clinical trials in orange or preclinical development in purple. And I think the point of my slide that I really wanted to drive home is this is coming, that these are under development in all of these different disorders, and it's going to gradually roll out probably to a large number of genetic disorders in our program. And so we really want to help the payers understand what's coming and lay some groundwork there.
Yeah, rare disease, I think of rare disease, or I used to think of rare disease as being rare, but it's not terribly rare anymore. Meaning I think it's something on the order of 1 in 10 Americans have some form of rare disease. Are you seeing, Sharon, the topic of rare disease become more elevated in policy discussions? Are more people becoming aware of the topic?
Well, certainly my world is rare disease. But it does feel to me like there's a lot more interest. I will say that 10 or 15 years ago, there was not the kind of interest that we see today in rare disease. It was really hard to get anyone's, attention. And now, all the major pharmaceutical companies are in this space. There's a lot of activity around it. I think we all recognize how common rare diseases really are when you aggregate them. So now the key is finding ways, economies of scale, to make this work when you have a lot of people affected by very different diseases. How do you make that work from a commercial standpoint?
Rafael, at Mayo, obviously you are a standout in the world for care and have been working on service delivery related to gene therapy, I'm sure, for as long as it's been around, 10, 15 years, or maybe not quite that long. But how are you seeing gene therapy as a care tool playing out at Mayo? In other words, is it becoming more common? Is it easier and readily available, or is it, to the extent that it's been approved by the FDA, or is it still so cutting edge that it's hard to get your hands around?
No, that's a great question. I think we're at the point of inflection right now where our level of understanding of how many of those diseases are driven by very specific genetic changes allows us to postulate what the next steps are for the treatment. And sometimes that is corrective in the way that you augment something. And there's gene therapies, of course, that would be something that blocks something, right? I think we're still at that point of inflection. So it is something that we see more and more. The Mayo Clinic, we describe ourselves as being top of the pyramid. And by that, I mean that we focus on very sophisticated and complex disorders. That's an area where we think the sweet spot is for our clinical practice. And it goes without saying, taking it one step out, when you think about this segmentation or this approach in looking at the rare disorders, it turns out that by extrapolation, a lot of the diseases that we consider common also become more and more individualized, and therefore they're more and more unique. It's not necessarily to move them all the way to be rare disorders, but more and more we see approaches that have to be very, very much tailor designed for the patient with the different diagnoses. And this is across the board, in neurosciences and cancer and everything else we deal with at our institution.
Jen, I wonder, I wonder if you can give us kind of a scope for a minute of the history of genetic therapy. I just said it's been around 10 or 15 years. That's not exactly accurate, but I remember that, I remember things like, I think Dolly, the sheep that was cloned back in the 90s, and the conversation back then about being able to manipulate genes in such a way to improve health and health status. Why don't you just give us a scope of what working in this field has been like for the last number of years?
Right. No, and this is where my head goes to wearing two hats, right? So I'm a bench scientist. I trained at the University of Pennsylvania, and I'll date myself back in the early 90s, which was the advent of gene therapy at the University of Pennsylvania. But to your point, it was even before that, right? The Human Genome Project, the excitement around understanding genetics, that in medicine has been around for a very long time, but it wasn't until 90s to 2000s that we really started to see some progress and some pausing, right? It's a very powerful science technology. These are diseases that we need to understand. We need to understand the root, the genetics of. And so it's taken us some time and some due diligence and some real work to get to where we are today. But I'm proud to be here on this panel in 2022 to say that we're actually having these types of conversations, as Raphael said, at an inflection point where we're starting to think about the practicalities of it, the access pieces, the different, it's one thing to make a medicine, it's one thing to think about administration, delivery, logistics, equitable access, cost, monitoring, all that taken into account to make sure that it gets to the patient. So it's been a long journey, not just 10 or 15 years, but I'm glad that we're at this point where we're actually starting to talk about practice.
Let me just stick with this question of scoping for a minute and ask Jen. I know in the 2000s, there was some question about the US's ability to keep pace with some of this science, given some of the restrictions on stem cell research. I know other countries took a different policy tack. How does the United States compare to other nations in terms of our research and our capabilities in genetic or gene therapy these days?
My focus has always been in the AAV, so the adeno-associated viral genome genetic medicine approach. I think Raphael actually might be a better person to answer this because he has a wider breadth in this space and maybe can touch on a little bit of the stem cell history. Raphael,
you want to jump in on this one?
Yes. So I think without a doubt, and we've seen historically a leadership for U.S.-based research and innovation and entrepreneurship in this field. But I think it is clear that many other nations are developing capabilities that could rival some of the things we're seeing here in the United States. So I'll give you as an example, we've seen Asia Pacific very impressive developments in the development of gene therapies, of tools that are being used to think about the fight against cancer. So like everything else, we're happy with, whenever there's a new solution for patients, but I would say that we have to remain focused as well too, to keep that vibrant environment here within the United States, because we have such an environment that can not only be focused on that, but actually benefit from the expansion of what we have with other biomanufacturing, with new drug development, with the clinical trials and so forth. But in summary, I would say, yes, I think we still have a significant leadership role, but with clear talent emerging from across the world.
Yeah. So Danny, we talked about this sort of multi-decade timeline, multi-nation approach. How are you seeing this topic play out in Arizona state policy, legislative politics, and rulemaking?
No, this is a great transition question to me because it comes down to who's telling the better story about this and how are you framing the story when you talk about it. Because the one thing that we know is a lot of times is science is outpacing policymakers on this topic, that they're making constant advances and the legislative process is not known for its speed, and something I was going to talk about a little bit later, but happy to do it now. When you think of a scientist, you think of a light bulb coming on. When you think of the legislative process, you always hear about the sausage being made, and that's a very slow process. So we do lag behind sometimes, and these ideas, they sound so out there. When you hear gene therapy, you think about, like you said, Dolly. That's not an association I would ever make when I talk to a state legislator about this. I would talk about how we're trying to help, identify, screen for, and correct, genes that aren't behaving as they should. And these are realistic solutions that we're looking at right now, and we can help real people every day in Arizona. And those are the differences we're making down at the legislature. And I think Arizona has gone from one of the slower states to one of the faster states in how we respond to these things as well.
Your slide, Danny, is teed up next and talks a little bit about the chamber and some of the solutions. Why don't you walk us through it?
Yeah, no, happy to do it. Thanks again for having me on. And unlike the other slides you'll see, I don't have a lot of pictures or graphics. And it's probably because, I'm the person on this panel who does the most talking for a living, I think, about, policy down at the legislature. So quickly at the top, I want to give you the mission statement of what the chamber is and why we care about this. we're dedicated to, providing access to innovative and affordable healthcare and bringing the overall costs down in the system where we can to all of our members in the state. So that's where we come in. And again, it comes down to, are we telling a better story than people who might oppose? And when you look at the economics of gene therapy, this is a big discussion right now, because if you were to Google gene therapy or people hear about it, the one thing they hear about a lot is just what the cost is. But we're not thinking or talking about cost the right way a lot of times. When you deal with rare diseases, Sharon mentioned, you need to look at it on an annualized basis over the cost of a lifetime, because gene therapy has the potential to actually save money and actually save a lot of heartburn and heartache and for the patients and the families involved with it. So, I tried to break down a couple of challenges and solutions as well. Patient access. There's a lot of tough stories that go into patient access right now with gene therapy. You have families who don't have access to high quality doctors who are willing to move, not just to another state, we're talking about different countries, relocate everything just so their child has a chance at this amazing treatment. We're talking about outdated value assessments. I just touched on that a little bit. When how do things cost, or how do you look at it? You really have to change it into a more holistic approach, take a step back and say, this is going to save money overall, because we're so used to treating diseases by the symptom instead of the root cause. So this is a new way and a new approach to doing that. And I think, lastly, I talked about the speed of science versus the speed of government, which I touched on quickly again. We got to be faster at the legislative level. And how we've done that in Arizona are with a couple of things. First thing, last year, we passed a new bill regarding newborn screening, where Arizona used to be one of the last states in the country to add newborn screening that would identify some of these just genetic issues. Now we will automatically, when the federal recommendations come in, Arizona will be one of the first states to do it, because we have to do it. We've taken the legislature out of the process. So we're increasing that speed. No politics, no legislature. It's now automatic the second it's recognized federally, and that's good for patients. When we're talking about access, we've become probably, if not the number one state, definitely in the top 3 for telemedicine and telehealth. Mm-hmm. We're allowing patients to see the best doctors around the country, and we've done that through cross-state licensing reciprocity. So we recognize the ability for doctors to practice across state lines, so you don't have to relocate completely. You can see whoever you want to see from your state now. We're doing what we can to put patients first. We're also doing parity in payment for providers if they provide mental health. So we're trying to make it so telehealth is thought of as a more traditional kind of practice as well. So we're trying to bring that again into the future. So, this is all about one thing. This is kind of my last point I'll make before we can get into discussion. That's helping government clear the tracks so science can win, and also hope. We don't ever want to see government be a burden. We don't ever want to hear these stories about how, you were a parent of a child who couldn't get their kid into a clinical trial because of government burdens or hurdles. So we want to do what we can to speed up that process and work together with the medical community.
So Danny, we don't have a health plan represented here. Obviously, employers are in many cases a primary payer. It goes through health plans and or self-insured ERISA models. But health plans, a health plan association might argue that these medicines are great and transformational and revolutionary, but they are so costly in many cases, so costly that it warps the entire risk pool for everybody else. Sounds like that's not the argument that you at the chamber are taking, that that you are highlighting the value-based payment methodologies instead. How do you sort of grapple with that cost of these, the cost of these new medicines, precision medicines, within a context of, an employee can rotate off an employer's plan, they can leave. And so that employer might be stuck with the bill for some extended period of time, even when that employee has left.
No, that's a very good question and a very good point. And you're right. We represent, the largest employers in the state here at the chamber. So this issue comes up. But again, it's about the total cost and the total value to the system. So you have to take a step back and start looking at the big picture here. And I can tell you from my time, when I was in the government side of this, we did that in Arizona. Arizona is one of a handful of states that allows for value-based purchasing when it comes to Medicaid contracts. So with their state access system that, is by far the largest provider, they've recognized that you have to look at patient outcomes and change your perspective, and not just about that initial upfront cost. And that's what our employers are doing. And that's what the state is doing as a whole. And we're happy happy to be participating in that conversation. Because again, if you were to just give an example, look at an oncology drug, and Dr. Fonseca could speak to this better than I could, it's probably annualized anywhere from 100,000 to 250,000 on 1 year. But there's multiple years where patients might be on that. Talking about gene therapy for a one-time cost versus a lifetime of treatment. It's innovative, it's life-saving, and it will bring the cost down, we believe.
Yeah,
Rafael,
DJ, maybe I could expand on that, because I think this is such a critical point what Danny is making. And I think we have outdated models of assessing the worth or the value of some of this intervention, in particular with gene therapy. When it's a one-off intervention, you have to think about the cost and the benefit as well too over the lifetime of the person. So I feel like one of the biggest mistakes is to look at the sticker price of anything we do. We have to look at the total cost of care, especially when you think about medicines. You have to take over a lifetime for whatever condition is. Even if one thinks about diabetes and hypertension, one can think of it like you're going to be paying rent forever. But if you actually do gene therapies, in some situations, this would be like paying cash up front for your house. And then actually, even if you have a high sticker price, but you have a person who's not going to be incurring healthcare utilization down the line because of repeated need for treatments, or they have a decreased economic output, the results can be massive gains. Now, this analogy is not mine. I'm going to put a plug in for a book I read, The Great American Drug Deal by Peter Kolchinsky, where he makes this difference between the rent and the mortgage. And I think it's a fantastic way to explain why we're going to see the value come forward as we think about these novel therapies that may be, in some situations, one-off and done.
Jen, I wonder, I know you are a scientist and don't spend perhaps a lot of time talking about pro formas and financing, but I wonder how you think about this conversation related to payment.
Well, I'll add two things that came to mind as they were speaking, because I agree with them all, and you're correct. I don't spend my day job thinking about this, but I think from a scientific perspective, there's also the cost of innovation, right? Innovation is not cheap. It takes a long time, a lot of scientists, a lot of trial and error, a lot of clinical trials. So there's that piece. The second piece is, as a human being, what's the cost of helping an individual with a rare disease? I mean, how do you put a price or a value on that? It's multifactorial to me, let's just say. And so that, as a scientist and as a human being, I have some difficulty with in some of these old models, as Rafael said, they're a little outdated.
Yeah, if government doesn't always keep pace with the science, it's clear sometimes healthcare payment doesn't always keep pace with science either. I want to jump to your next slide, or our next slide that you've brought for us here, Jen. Why don't you walk us through what you've teed up?
Sure, and perfect transition as always. I just want to thank you all for such a great discussion. And you know, wearing the multiple hats I do, I wanted to talk about the promise, if you will, of gene therapy. And I always like to start off at the top of the slide with a little discussion on the unmet need, because any discussion on promise in rare disease should begin with that. And it's really all about the numbers in that top row. Approximately 7,000 rare diseases across the world, and a whopping 95% have limited to no approved treatment options. Unbelievable. Making the patients collectively with rare disease, if you think about it, one of the most underserved communities in medicine today. An estimated half of those affected are children. And most important for this particular discussion today, 80% of those diseases, those rare diseases, are rooted in the genetics. Finally, I'll say that people living with rare diseases, rare genetic diseases, the need for, as we've discussed today, innovation and innovative treatments is really urgent. Taking that together, what's the impact? What's the potential impact in the center of the slide? It's really to address the underlying cause of rare diseases at the root, meaning the genetics, not the symptoms, not to provide supportive care, the underlying biology behind that disease. That's what we scientists like to think about. If you think about that, the potential impact is maybe there's a treatment where there currently isn't any. Maybe there's a potential to reduce costs and burden of disease. The potential, as I mentioned in the previous discussion, to improve someone's life. What's the value of that? To improve the care of a patient, the caregiver's quality of life even. And I will add that ultimately the ability to realize any potential of gene therapy to treat rare disease depends on listening to and addressing the patient needs. We always need to have them at the table telling us what they're thinking, how they're feeling, and what they need. At the bottom, I think about a couple challenges. Gene therapy is straightforward to some people in principle, incredibly scientifically complex in practice. It is very powerful. So we need to think about a couple things. First and foremost, on the left, care, specialist delivered care, the infrastructure that's required to deliver these gene therapies. Are we prepared at the various institutions across the US to deliver this technology, this top-notch, new, innovative care? The who, what, when, and how of access. How do we ensure that everybody has access to this and that it's equitable? And there still are a lot of uncertainties. As I said, it's been a long road, and we're almost acting like detectives in medicine, if you will, in the evolving science and medicine of gene therapy. There's still a lot of things for us to understand, to learn, to do our due diligence, to monitor, both in the short term and in the long term. This, if you will, I've heard from some of my physician friends, is really an irreversible decision to make to a patient. This is not something that you can say, no more refills, I can dose adjust, I can just wash you out. This is a major, innovative, life-changing decision, and we need to think about it as such. I'll pause there.
Sharon, I wonder what you make of Jen's slides and her comments.
Yeah, I mean, I think it's spot on. I think it's a great overview of where we are with gene therapy and the promise and the need. I think one thing that will help in the long run with the discussion about the economics is we will get better. We have gradually been getting better. I've been in the space for about 20 years, probably about the same time as Jennifer. We have improved year after year after year with gene therapy. And so it will become more cost effective. We will get there. And so I think that's part of it. And then I think the other thing that I'd like to comment on too is this discussion about the ethics of gene therapy. It is true. It's a permanent change to someone. So what we see in particular, parents of a child who has a pediatric disease are put in a very difficult position because they have to make a decision without always understanding all of the science and all of the implications. So there's a huge, I think a huge requirement for the physician to be very clear who does the informed consent. And then the parents have to decide, if I enroll my child in this gene therapy trial, I've done something permanent. If it doesn't work, my child can't be redosed. My child may not be eligible for another trial. So I think navigating the ethics behind that, and it falls squarely on the patient or the parents in the case of a pediatric disease. I think that's been a big challenge and something that we've tried to help our community in the neuromuscular disease space navigate.
Mm-hmm.
I wonder if you, Sharon, or really any of you might have observations about an advocacy topic. Specifically, I'm thinking about mental health as an allegory, and mental health in that space. Some folks would argue that adults are better organized to advocate for mental health than children, and that the children's advocacy organizations are sometimes not as well organized. And so more attention may fall on adult mental health in the advocacy world than pediatric mental health. That's just an opinion I've heard. I'm not saying it's right, wrong, or indifferent, but I wonder if there are lessons there, maybe the converse in gene therapy, because so many of the genetic disorders are focused on people earlier in their life. And when they don't make it, they often pass on, obviously, earlier in their life. I wonder if you see a difference in advocacy, that maybe this is something that we will see, or we are seeing maybe more pediatric advocates or children's advocates, family advocates speaking up more loudly than people who might be 30 or 40 or 50 living with some of these diseases. Or maybe it is like mental health, where adults are better organized on this and getting more attention than kids. Does anyone have an observation about how that might break down?
I can tell you what I've seen at the legislature a little bit. And if you go back to that newborn screening bill, they videotaped in video conferencing, parents of children with some of these screens, with some of these genetic disorders. If had they been screened, they might have had different symptoms throughout their life. And it was incredibly powerful to see that. So it was kind of a combination of both the parent and the child So I would say there is a lot of organization around this. Again, it's important to tell the right story when you talk about this. But no, I've seen it both with children, with parents, and with the medical community. And again, transparency, informed consent, that's all very important. But again, we have to be honest about this is innovative, but it has so much potential. And anybody who's ever been associated with this, you call them rare, but when you look at those numbers, 400 million, out there, 200 million of which are probably children. And if you're someone, who's as a family member who's been through that, it touches a lot of people. I've always hated it, the drugs to treat a lot of these are referred to as orphan drugs, because you don't leave behind orphans. Every family member who works with us, every caregiver is touched throughout the rest of their life and impacted. So it's tremendously strong.
If I may add, DJ, I think I would defer to Sharon or one of the advocacy organizations to comment specifically on your question. But I think where I took it was also to make sure and ensure, and I think that's what programs like this are doing, that all of us that are involved, whether it's the biopharma developers, the advocacy, the physicians, the Chamber of Commerce, but the payers, the legislators, everybody involved end to end is educated. I think that can go so far. And I think about the patient and the family and the parents, it can't be a line item in a bill. It can't be something on a piece of paper that you hear about. It has to be someone telling their story. And I think everyone has gotten much, much better about that and thinking about the patient and what they're going through. You can learn so much by just sitting and talking and hearing their story and little things that you didn't even know affected them. And I think that's the beauty of where we are today. And so we need to bring that to more of the audience that's involved in making some of these decisions so they can see it as more than just a line on a piece of paper when they're deciding something, frankly.
Yeah. Raphael, I want to turn to your slide here that you have teed up, and I can't wait for you to tell me why an elephant is on this slide.
Well, first of all, again, thank you. And I'll walk you through what I present here with 4 images that I think present to our audience first some explanations of the current status of some of these things and where we're going into the future. I did not mention during my introduction, in my clinical practice, I have a very active clinical practice. So I am a cancer doctor and I am a hematologist. So we deal with blood disorders. And the reason I mentioned that, on the top left, what you see there is an image of what's supposed to be a blood vessel. It's a blood vessel that seems to be clogged. And that's what happens to people who have hemoglobin disorders, things like sickle cell disease and thalassemia. Normally our red cells are supposed to be flexible to easily pass through those capillaries in our body. But when you have sickle cell disease, they change in their form so that they obstruct the blood flow. And that's what's depicted with this image. And what we're seeing are efforts that are already showing that if you alter the mechanisms by which the bone marrow of a person expresses the different types of the hemoglobins, these are the proteins inside the red cells, you can actually revert some of these changes. Now, this is somewhat early, but the potential for this to have someone who's born with one of those disorders return to normal red cell function is just enormous. This is a worldwide problem. It's a problem that is associated with pain, serious medical problems, a shorter lifespan, and great expenditures for the health system. So I'm very, very excited about what we're seeing there with red cell disorders. Another example is what you have on the bottom left. We have certain genes in our body that we can dispense of in a certain proportion. There's, for instance, this gene. I won't go into all the details. That is called TTR, which helps carry vitamin A around our body. But you don't need a lot of it. You need just a little bit of that protein, that carrier protein, to be present in our body. And a recent study, which was published in the main medical journal, the New England Journal of Medicine, shows that if you actually reduce the concentration of this gene, and this can be done simply through the genetic alteration of the genes that are located in the liver, you can decrease, as you see in the bottom right part of that portion, 87% the production of that protein. Now, this protein is problematic because it's sticky. And if it stays long around in the body, it starts forming deposits. Think of it like, hard water and calcium deposits. And people who have this sometimes have serious or life-ending diagnoses like heart failure. So this is being explored, and this would be life-changing for everyone who has the genetic abnormality. On the top right, what you see there are 2 cells. The orange one is meant to be a T cell that is attacking a cancer cells. Now we can take out this T cells. These are a part of the white cells of a person's body. We collect them from their bloodstream. and retrain them or program them through genetic engineering to go back and directly attack the target cells that are cancer cells. And this is not science fiction. This is something we already are starting to do in the clinic. So for some of the patients that I see with multiple myeloma, that's a condition I see the most, we already have an FDA-approved product of cells that were put out of the body, genetically engineered, infused back. And in some of the recent clinical trials, we have over 90% response rate for this type of intervention. So this is really, really exciting in our field. And lastly, and to your main question, why do we have an elephant there? Well, I put that just perhaps as a glimpse of what the future could be like, because it turns out people realize that the incidence of cancer in elephants is minimal. And no one had taken notice of this until someone has started to ask questions, well, is there something different about their genome? It turns out that elephants have redundant copies of genes that are kind of the guardians of the genomes. There's a gene called TP53 that makes sure nothing goes wrong with our genetic sequences, that everything stays in check. We have the right spelling for each one of those genes. And elephants can have up to 40 copies of that gene. Normally, we only have 2. So you can imagine a future where we start thinking about even preventive genetic intervention, so that could there be a future where humans don't have cancer? Well, if we can emulate what the elephants do, the answer is yes. So these are more very specific clinical examples of why I think the field is so exciting.
Danny, I know I get excited about that. I just learned about this elephant gene here from Raphael a couple of days ago. But it does strike me that the way we talk about science in our political ecosystem is not always putting wind in the sails of innovation. What do you connect the dots between what Raphael is talking about, the possibility of the future in a science-based and science-led healthcare system, and the political reality of trying to talk about health policy in America in 2022?
First of all, I too, when I learned about the elephants not getting cancer, I was fascinated and ended up reading for hours about it. So again, I think Dr. Fonseca has the coolest slide out of all of us. But that aside, to your point, I don't think this is something that's new to 2022. I think if you look throughout history, there's always been a little bit of a delay between science and politics, or sometimes a misunderstanding. And whether it is a belief that when you're altering or talking about genes, it somehow invokes religious opposition or something else that can influence, the political outcomes, that's not an area we want to get to at all. We're talking about patients, we're talking about people, and we're talking about what this can mean for families in everyday lives. And when you do that, when you get down on a level and people meet with these children, and they meet with their parents, and again, it's hard to meet someone who hasn't had an interaction with this. For my family, we have cystic fibrosis in our family, and we lost my uncle before his 18th birthday, and so gene therapy is one of the greatest hopes for people with CF. So this is a realistic thing for a lot of people out there. Politics shouldn't come into play, except how can we provide the best kind of access? How can we lower the overall cost? And how can we, just help get out of the way so that science and hope can have a chance? And that's the story you have to tell, and make sure the right people are telling it. So yeah, I do think words matter and the story matters, but it is a good story to tell, and it's amazing what's happening. And everyone who's listening should be excited about this innovation.
Aaron, I wonder what your thoughts are on this topic of this time in which we are living, where there is an animated anti-science component to our society. How do you sort of think about educating folks who may have just general reluctance to science?
Yeah, well, I do think it's a pendulum. I think that swings back and forth. And I think we've seen some anti-science sentiment, and I'm hopeful that that will change. It may not change on its own. We probably do need to do a better job of educating. And I think not just educating people, but showing them. So I think when Danny mentioned stories, it's important to talk about stories. So I showed in my slide that we do have one approved gene therapy in this space, and it's for spinal muscular atrophy, which is a fatal infant disease. So these are babies who won't live past the age of 2, almost ever. And with the gene therapy treatment, they're not only living, but they're walking, they're meeting motor milestones. This is, as close as you can get to magic. This is where we are with our science today. So I think as we show people the benefits, that's going to have, and tell those stories, that'll have some impact. But I am hopeful that that pendulum will gradually swing in another direction.
Yeah. One pendulum that I think is on the horizon, swinging towards us, as shown in this next slide. This is one that we've brought to the conversation, and this shows data in two ways. Shows the gene therapy, cell and gene therapy, and new medicines that are being developed in the clinical and preclinical, and those that have been approved in the launch stages, and how those compare across essentially scientific sophistication. So you can see the little light blue amount there at the very top is the cell and gene therapy. And if you look on the far right on the launched column, you see it's just a very small portion of the overall percentage of medicines that have been launched in recent years, but that you can see in the clinical stage of the pipeline and in the preclinical stage of the pipeline, the overall percentage of medicines that are in this space is significantly higher. You can see that in absolute terms on those three columns on the left, particularly the clinical stage cell and gene therapies being significantly higher in absolute terms than those that have been launched. It provides a little bit of an infographic on the overall conversation that we're having, that we may not have too many cell and gene therapies yet approved in the market, but we have a lot of stuff coming down the pipeline. And it's at least my view that, as you've heard a little bit here today, that we are not always supremely adept and well prepared at the legislative level, at the state policymaking level, to respond to these. And I think sometimes we think that this is always a federal policy matter, and there certainly is a federal policy piece, but state politics and state policy matters significantly in actually getting these new medicines across that last mile into the patients that need them the most. So, Jen, I wonder, when you think about this, does this slide excite you? I mean, it must to some degree to see all of these things coming, or does it give you apprehension? Tell me what your response is to this slide.
I've been around, as Sharon said, we've both been around a long time. This is very exciting for us. I think, it does come with apprehension. I think the process of science and innovation takes time. We used to say shots on goal. So you always start off with programs early, lots of things in the mix. And then as you put them through the rigor of scientific investigation, some things will drop off and you move forward with others. So that's kind of also what you're seeing. I think what kind of connects the two discussions, this and the one we were just having, is what used to make me pause was even before COVID, as I thought about the innovations and the advent of this gene therapy, if you will, movement in science and medicine. Were we ready in the United States for that? And I was thinking of it from a cost, from an infrastructure, all of that piece. And then COVID hit, and that just adds to it. You have cost again, you have infrastructure again, but now you have it under the COVID umbrella. But then the beauty of it came out as we've been talking, telehealth has emerged. And you mentioned that in Arizona, telehealth here where I am in Connecticut is huge. All these beautiful silver linings came. So yes, I'm excited. I'm optimistic. I think we're going to continue to see challenges, but we'll meet them. We'll do our investigation, our rigor, our due diligence, and we'll just keep moving. We have to keep moving forward. We say here that we have to continue pioneering. If it was easy, it wouldn't be worth getting up in the morning. You have to be a pioneer.
Raphael, I wonder what your thoughts are about this slide. And I wonder how you keep up with the pace of innovation when I recognize you have a specialty in your specific clinical practice, but how does Mayo keep up with the pace of innovation when you see all of these things coming through the pipeline?
Yes, well, I'll answer the second one first, and I'll go to your first question. The second one, it's impossible to keep up to date with everything. So I just specialize in myeloma, as I mentioned, and I get emails with all the articles that are published, and it would take me pretty much half of the month to read everything that is being published. And so if you're an oncologist out in the community, and this is 2% of your clinical practice, so good luck with that. So we try to create systems of continued education, summaries. We have medical education, but that's a long topic, perhaps for another conversation on how we do that. Now, I should tell you, by nature, I'm predisposed to be very optimistic. And, Michael Burns from TGen used to say he's pathologically optimist. So I align with that. You come out and you think the sun is shining every day, which is true in the state of Arizona, but you see what's happening, which is just incredible. And, for me, one of the things that I think we should think about when you think about the legislative framework is that I think science goes very much hand in hand with the same philosophy or ethos that we see around us in the United States, which is, as Taleb would say, you failed, you stand up again, roll up your sleeves and go to the next opportunity. And that's the essence of science. We try and you have all these villages with these theories, and it just takes one student that shows you the light of what's right. And then you have to move on to the next village. But once you find an answer, that translates into something beneficial. And when I see a graph like what you're showing there with that growth in gene and cell therapy, I'm just wondering, what is that light blue component? What of that is neurosciences? Is there something there additionally in cancer that I haven't thought about? And so I think from the perspective that we will all be patients, this is a good slide. These are new treatments that will be available for us in the future. What economists refer to as the value of innovation, right? The value of options, and that is those options that will open up into the future because of the research that's going on right now.
Annie, what do you think of when you think of the conversations that legislators are going to have as a result of these new medicines coming to market and the regulatory implications for those? Does just give us a sense of what you think those conversations might look like in the years ahead?
Sure, absolutely. I do want to just touch your other question about, can the states keep up, or do they view it more as a federal responsibility? This is one area. Well, there's a lot of areas. You've heard that states are the laboratories of democracy. This is one area where states are leading. If you look at the value-based payment model, that came out of the states. The states are showing how you can look at value holistically now. And I think we can serve as an example for not only other states out there, but the rest of, the federal government as well, and even other countries that are falling behind on this. So states are leaders on this. So when you talk about what kind of conversations we have to have, looking at your graph, which I think is extremely exciting. Again, there's not a legislator down there when you look at all 60 of our members, that don't have a family member or someone they know who's been through or connected to a rare disease. So this is exciting, and we have to talk about it in that way. We have to get ready for this. We have to make sure that when these are ready to go to market or clinical trial, that they won't have somebody who has a child and say, "I'm sorry, we're not ready to cover that yet," or there's an outdated law that's stopping you. We have to do everything we can to clear the way for that kind of innovation. That's what we have to say. And we have to make sure we never go backwards when it comes to science and innovation in Arizona. So those are the conversations we're having, and we're going to continue to have. And again, the best models, the best advocates, I'm going to throw it to Sharon, are the patients, are the children, are the parents. And love having them down at the Capitol, love having them on video, love having them around to support this position as well.
I want to give everybody an opportunity here as we start to near the end to give us a sense of what gives you hope here in January of 2022. Sharon, I want to start with you. As you look out to the calendar year ahead and within the context of the conversation that we've just had, what gives you hope about the work ahead in the year 2022?
Yeah, I think I'm probably pathologically optimistic as well. I think this potential for the first time of being able to treat these diseases that were absolutely devastating and untreatable, and that, being a neurologist is going to be a completely different profession. Instead of diagnosing people, you're going to be able to diagnose and treat people, which is something that didn't happen with genetic neurological disorders in the past. So I think we're just on the cusp of a sort of brave new world where, a diagnosis is the first step. It's not a devastating end. It's the first step to getting a treatment. And I think that the key thing we have to do is make sure that we're not in a position where we can technically treat someone, but we're not able to do it because of these other types of obstacles, from payment to infrastructure to treatment. We need to make sure we've got all the pieces in place, because that would just be devastating to know that we could technically do it, but there are other obstacles. So I am optimistic that we're going to solve those.
Raphael, how about you? What gives you hope as you look out on the year ahead?
Oh, I completely concur with Sharon. I've always thought, like in waves, medicine has dealt with, first wave of dealing with infectious diseases, and COVID notwithstanding, there's a lot of progress in that area. So we understand that much better. Then huge progress in cardiovascular diseases as well, too, in the management of coronary artery disease, et cetera. I think we're in the midst of probably one of the largest, revolutions we'll see in the treatment of cancer. And that will be in no small part because of gene and cellular therapy. But I always say the fourth wave that I think is we need to move also to neurosciences and aging. And that is an area that has been in many ways a black box, and for which there have not been many therapeutic options. So I just support and hope that what Sharon is saying becomes true, because I think as we all become healthier and live longer, then we're going to have to deal with that as well too. So we want to maximize, the human experience and do so with functionality in our longevity. So that gets me pretty excited.
Danny, when you look at 2022, what gives you hope?
I want to start off, I might be the only one to say this, but I'm not known as an optimist. I'm not an internal optimist. I'm more of a realist. So sometimes people even call me Eeyore. But on this topic, I am very optimistic because, again, it's just never before are we seeing the kind of advances at the speed that we're seeing than right now. And it's so exciting. You heard me mention before, my family is personally impacted from a rare disease in the form of cystic fibrosis. So when I look at the studies that are being done there, I read every article that gets sent out. That's just one of them. So what am I seeing that makes me excited? I'm seeing that right now, whether it's in terms of the global pandemic or not, the heroes of this story are the scientists, are the treatments. They're the people who are making it so society is getting back to whatever kind of normal you want to call it, but they're the ones who've helped us get there. And so it's so great to be on that side. And I have to tell you that the employers who I represent in terms of total costs and issues like that, they care about their employees. They care about them in a way that they want to contribute and make sure their families are taken care of. And again, it makes sense when you look at costs holistically. So I'm optimistic about that. I'm optimistic that more and more states are looking at value-based payment models and outcome-based payment models. It's the free market system at work, and it's showing that it really works. So all of that makes me optimistic, and it does. It actually takes a lot to make me optimistic. So I feel like 2022 is going to be a good year for this.
Jennifer, how about you? What gives you hope for the year ahead?
Well, I'm a warrior, so I guess that adds a third piece to it. I think, I always loved science. So back in the 1970s, I used to do experiments in the back of my dad's high school biology classroom by myself. So to be in this exciting time of science and medicine is absolutely incredible. And I think I'm so optimistic that we're finally getting to the point where we have these medicines that we've all talked about and thought about, and some are launched and some are getting there. I think the worrier in me echoes what Sharon was said. It would be just unthinkable to go through and develop something and have it and not have someone get it. And that's what keeps me up at night. It's all the other pieces, all the other people that we need to work with, the village and the mountains we need to move to make this become a reality for someone. That's what makes me worry. But it's forums like this that get us all together to start. We're starting early, at least in my space of Duchenne. I just think it's an fabulous time to be here, and I'll continue to worry and move the mountains.
Dr. Jennifer Hodge, the gene therapy lead in the U.S. for Pfizer. Dr. Rafael Fonseca, the chief innovation officer at the Mayo Clinic. Dr. Sharon Hesterly, the chief research officer at muscular dystrophy at the MDA Muscular Dystrophy Association, and the inimitable Danny Seiden, president and chief executive officer at the Arizona Chamber of Commerce and Industry. Thank you all for being with us. This show will be up on our site at stateofreform.com, and you'll be able to come back and watch it again. I appreciate all of the support you provide us. Take care, everybody.